So improvement of plus disease were at 1 week in 93% of the babies, and involution of neovascularization was found at 4 weeks in 81% of the babies, and vascularization of retina was found at 12 weeks in 61% of the babies. Of 87 percent of the infants, there was regression, whereas 13% showed recurrence rate, and recurrence was more in AP-ROP, that is 30%, and in type 1 ROP it was 5%. So the follow-up period post treatment was for 14.5 months, and in case of treatment where treatment failed, it was the mean follow-up period was 19.6 months. It was longer. Some cases showed recurrence, and as we can see in these images, the ridges reappeared, and in those cases diode ray laser was given, laser photocoagulation, and post laser therapy we can see the image of regression. So the complications following treatment observed were subconjunctival hemorrhage at the injection site was observed in 4 babies. A recurrence occurred in 20 of the babies, and progression nil, and one had vitreous hemorrhage and cataract in 2 of the babies. So our study suggests regression of plus disease and stage 3 expected within first 4 weeks after bevacizumab treatment. Recurrence may occur despite initial regression, so we require careful follow-up. Even though we did not observe any unfavorable events after anti-VEGF injection, more robust and large control trial with longer duration of follow-up is needed to monitor the side effects of drug on infants. These are my references. Thank you.
You say 20 failures.
Yeah.
20 recurrences.
Yes.
So all were given repeat injection?
No, not repeat injection. We laser.
So following laser, there is no recurrence?
No, we followed up to an average of 9.
Follow-up period, there is
No,
recurrence
after laser.
Third presenter is Dr. Chandana Priyadarshini.
Good morning, sir. Today my presentation was a study of association between disorganized retinal inner layers called DRIL and visual acuity in diabetic macular edema. There are no financial disclosures for my study. Coming to introduction, diabetic macular edema is a sight-threatening manifestation of diabetic retinopathy affecting almost 30% of individuals with more than 20 years of diabetes mellitus. Diabetic retinopathy affects the entire neurovascular unit of the retina. Recent studies have identified retinal dysfunction and structural changes resulting from neuroretinal disruption, sometimes occurring prior to the characteristic microvascular findings of diabetic retinopathy. Retinal tissue has a very organized structure, and disturbance of its layers, especially in the macular region, can reduce the visual function. So spectral domain optical coherence tomography, or called SDOCT, provides high resolution non-contact imaging of the retinal structure that can be used as a qualitative and quantitative tool to evaluate DME. OCT is the only method that provides cross-sectional images of the anatomy and topographic structure and pathologies of the retinal layers. These tools would substantially enhance patient counseling, improve risk stratification, advance clinical management, and influence selection of eyes for clinical studies targeting DME. My main aim of the study is to evaluate the association between morphology of disorganized retinal inner layers and visual acuity in patients diagnosed to have diabetic macular edema. My study was a cross-sectional observational study with 50 cases attending the OPD. It is a convenient type of sampling with 1 year of duration of the study. All the demographic details were collected, and the study was in accordance with the ethical committee guidelines, and all the patients were informed about the purpose of the study, and an informed consent was obtained. Coming to methodology, best corrected visual acuity in logMO format was recorded, and IOV by Goldman applanation tonometry was done. Pupillary dilatation was done by 1% tropicamide eye drops after checking IOP. Dilated fundus examination with a direct ophthalmoscope and plus 90 lens, and in case of media haziness, an indirect ophthalmoscopy was done in this patient. On fundus examination, diabetic retinopathic severity was graded using EDTRS protocol. And basic blood investigations were performed like lipid profile, serum creatinine, and HbA1c. Coming to SDOCT, it was used for acquiring Sing in DME, and the OCT used is SDOCT Topcon Master 2 machine was used. In it, macular cube protocol, central macular thickness was measured. Foveal center was determined as an area that is devoid of inner retinal layers in macular region, and pathomorphology within 1 mm area around fovea was assessed for each eye. Two graders masked to the visual acuity and severity of diabetic retinopathy was analyzed with these images. Drill is defined as horizontal extent in microns for which any boundary between the ganglion cell and the inner plexiform complex, inner nuclear layer and outer plexiform layer could not be identified. Coming to my inclusion criteria, patients with type 2 diabetes mellitus as per ADI criteria was taken, and diabetes mellitus with greater than 10 years of duration and age greater than 40 years. Center involving diabetic macular edema defined as baseline SDOCT with CMT greater than 320 microns for men and more than 305 microns for women were taken. Exclusion criteria: patient with significant media opacity, patients who have underwent cataract surgery in the preceding 3 months, and patients with non-diabetic retinal pathologies affecting visual acuity, and patients who received anti-VEGF therapies or macular lasers to the eye or PRPs in preceding 6 months were excluded. Coming to my evaluation criteria on OCT, central foveal thickness and extent of drill were taken. Cyst, hyperreflective foci, microaneurysms, cone, outer tip visibility, and external limiting membrane of photoreceptor disruption reflectivity were evaluated. Coming to data analysis, this data was analyzed using Microsoft Excel and SPSS version of software. And Pearson correlation coefficient, independent sample t-test were taken for my statistical analysis. P-value less than 0.05 was taken as significant. Coming to my results, central macular thickness increases as drill increases, which in turn worsens the visual acuity, and the drill extent showed the negative correlation with the visual acuity with Pearson correlation coefficient of 0.648. When compared with the other studies like Sun et al., which was disorganization of retinal inner layers as a predictor of visual acuity in eyes with center involved diabetic macular edema, who have taken 96 patients, and they concluded that disorganization of retinal inner layers in 1 mm foveal area is associated with visual acuity, and change in drill predicts future change in visual acuity. Coming to Radwan et al., where there were 55 patients were taken for association of disorganization of retinal inner layers with vision after resolving center involved diabetic macular edema, they concluded that the presence of drill at the baseline and its resolution patterns may have been associated with subsequent visual acuity after resolution of center involving diabetic macular edema. So my study concluded that disorganization of inner retinal layers is correlated with is a predictive biomarker for visual acuity in baseline center involving diabetic macular edema, and drill is a valuable and easily obtained non-invasive biomarker of visual acuity in diabetic macular edema. These are my references. Thank you.
So when the patient presented and you have studied the OCT
Yes,
and you followed up for 1 month, 1 year,
yes, sir.
right? During that you did not treat patient?
Sir?
You did not treat patient?
Actually, we were only, apart from treatment, we were only seeing the OCT findings, sir.
Yeah,
How they
but
were finding.
If you treat the patient, that
No
is
specific treatment, sir. Only drill changes were assessed.
patient has got macular edema, patient requires treatment, right? More than 360 is there, your.
Yes, sir.
So that patient does not require treatment?
Who are not coming with the criteria of any other treatments were taken, sir. Thank you.
Hello. You have a second presentation. Again, it is related to central thickness changes in PDR treated with intravitreal ranibizumab versus ranibizumab plus PRP.
Yes, sir. Good morning, everyone. This is my second presentation. The title is Central Retinal Thickness Changes in PDR Patients Treated with Intravitreal Ranibizumab and Ranibizumab with PRP. There are no financial disclosures for the study. Coming to introduction, diabetic retinopathy is a common complication of type 2 diabetes and is a leading cause of blindness in the working population in the world. Without timely treatment, 50% of the patients with proliferative diabetic retinopathy will lose their sight within 5 years. Retinal neovascularization represents an important risk factor for severe vision loss in patients with diabetic mellitus. Pan-retinal photocoagulation has been a gold standard for PDR treatment since 1980s as it arrests the progression of diabetic retinopathy by improving retinal oxygen supply and decreasing the subsequent production of vascular endothelial growth factors. Anti-VEGFs intravitreal therapies radically changed the outcome of DR due to combined anti-angiogenic and anti-edematous activities. Coming to the aim of the study, to compare central retinal thickness between eyes with proliferative diabetic retinopathy treated with intravitreal ranibizumab and intravitreal ranibizumab with pan-retinal photocoagulation. Coming to objectives of my study, it is to assess the changes in central retinal thickness in patients with PDR undergoing intravitreal ranibizumab and intravitreal ranibizumab with PRP and to compare the changes between these two groups. Coming to the study type, mine is a prospective observational study taking 30 eyes which are coming to the OPD, which were divided into 15 eyes in group A and 15 eyes into group B. Group A were given intravitreal ranibizumab and group B were given intravitreal ranibizumab along with PRP. It was a convenient sampling and the duration of study is 6 months. All the demographic details were collected and the study was in accordance with ethical committee guidelines. All the patients were informed about the purpose of the study and an informed consent was obtained. Institutional review board clearance was taken for the study. Coming to methodology, best corrected visual acuity in log format was recorded and IOP by Goldman appellation tonometry was done. Pupillary dilatation was done with 1% tropicamide eye drops after checking IOP. Dilated fundus examination with a direct ophthalmoscope plus 90 lens and in case of media haziness an indirect ophthalmoscopy was done in these patients. On fundus, diabetic retinopathy severity was graded using EDTRS protocol and a basic blood investigations like RVS and HbA1c were taken. Coming to the procedure of the study, the first group received intravitreal ranibizumab of 0.5 mg in 0.05 ml at baseline 4 weeks and 8 weeks. The second group received standard PRP treatment delivered as per routine clinical practice targeting non-perfusion areas along with intravitreal ranibizumab. PRP was performed using a single retinal specialist with NIDA green laser of 532 nanometers frequency. PRP was performed in 2 sessions with an interval of 15 days between the session and shots were delivered with a pulse duration of 0.2 seconds for a total of 1200 to 2000 burns. SDOCT was performed measuring central retinal thickness. Coming to inclusion criteria, patients with proliferative diabetic retinopathy defined as per EDTRS guidelines as follows: presence of neovascularization at the disc, presence of NVD associated with vitreous or preretinal hemorrhages, and neovascularization elsewhere with more than half disc area associated with vitreous or preretinal hemorrhages. And coming to exclusion criteria, patients with significant medial opacity, history of prior laser treatment or vitrectomy in the study eye, tractional retinal detachment, and patients with histories of ophthalmic diseases other than diabetic retinopathy and cataract, patients with intraocular surgeries except for cataract extraction, and patients with external ocular infections like conjunctivitis, keratitis or significant blepharitis were excluded. Coming to data analysis, the collected data was analyzed using Microsoft Excel and SPSS version, and statistical analysis was independent sample t-test and p-value less than 0.05 was taken as significant. Coming to my results, both group A and group B, independently both the results were significant with mean in group A taken as 0.56 plus or minus 0.15 after 1 month with a confidence interval of 0.48 to 0.64, and in group B 0.53 plus or minus with 0.14 and confidence interval of 0.45 to 0.61. Even central retinal thickness was significant after 1 month independently. Coming to discussion, when compared with the other group of studies, in Philpa et al., pan-retinal photocoagulation versus PRP plus intravitreal ranibizumab for high-risk proliferative diabetic retinopathy, where 40 patients were taken, and they concluded that intravitreal ranibizumab after PRP was associated with larger reduction in FLP at a week 48 compared with PRP alone in the eyes with high-risk PDR, and adjunctive use of IVR appears to protect against the modest visual acuity loss and macular swelling observed in eyes treated with PRP alone. Coming to Filugro et al., ranibizumab plus PRP versus PRP alone for high-risk proliferative diabetic retinopathy called Proteus study was done in 87 patients, and they concluded that intravitreal ranibizumab along with PRP was more effective than PRP monotherapy for neovascularization regression in high-risk PDR patients over 12 months. The limitations of my study was a shorter follow-up time period, and the conclusion is that intravitreal ranibizumab along with PRP was associated with larger reduction in central retinal thickness at 1 month when compared with intravitreal ranibizumab alone in patients with PDR. The additional use of PRP appears to protect against the visual function than intravitreal ranibizumab alone. Here are my references. Thank you.
How many cases did you find with opaque media? Question number one. Because when you start using the PDR, patient may have vitreous hemorrhage, patient may have TRD. So there must be large number of cases which can be
Yes, sir.
were excluded.
There are
Right.
so many of
And
associated
number two,
complications.
you are working opposite the thesis, opposite the school of thought where PRP causes macular edema. So here you are proving something that PRP
Yes, sir.
reduces the macular edema.
Yes, sir.
So you have to think about this.
Okay, sir. Thank you.
Good afternoon, everyone. I'm Dr. Priya Suman. I'm going to present on to study the association of HbA1c and serum lipid profile in diabetic retinopathy with CSMA. There is no financial disclosure. According to WHO, diabetes mellitus is defined as when a person has more than 2 reading of fasting plasma glucose of 126 mg per deciliter or glycosylated hemoglobin more than 6.5%. Diabetic retinopathy is among the most common cause of leading blindness, affecting the age group of 25 to 74 years of age, and is a frequent microvascular complication of diabetes mellitus. It is classified into 2 categories, type 1 which is 10% prevalence and type 2 which is 90% prevalence. According to WHO, India has 70 million people living with diabetes in 2015, which is estimated to increase up to 90 million in 2030. The pathogenesis is there is loss of pericytes, which leads to capillary basal membrane thickening, leading to microaneurysm formation and further leading to the breakdown of blood-retinal barrier. The measurement of HbA1c has been reported to be one of the well-established means of monitoring glycemic control in patients with diabetes mellitus. It reflects average plasma glucose over the previous 8 to 12 weeks. It is being used as a diagnostic test for diabetes as well as screening test for person at high risk of diabetes. The elevated serum lipid causes retinal hard oxidate formation, which leads to endothelial dysfunction causing breakdown of blood-retinal barrier. My aim is to study the association of HbA1c and serum lipid levels in diabetic retinopathy with CSME. This is a hospital-based cross-sectional study which included all type 2 diabetes mellitus patients above 40 years of age from December 2022 to June 2023 in 120 patients. Detailed diabetic status of the patient included age of the onset, duration of the disease, any medication. Detailed ophthalmic examination included best corrected visual acuity, slit lamp examination of anterior segment, detailed fundus evaluation with indirect ophthalmoscope, slit lamp biomicroscopy using 90D, OCT, FFA. Blood investigations done in this study were HbA1c level, serum lipid profile, random blood sugar. In this table, highest frequency of patients belong to the age group 55 to 64 years of age, followed by 50 to 54 years of age. Out of 120 patients, 53% were male and 46% were females. In this table, highest frequency of patients were having duration of diabetes in 11 to 15 years, followed by 16 to 20 years. In this table, highest frequency patients were on oral hypoglycemic agent, followed by 24% were on insulin, 13% on lifestyle modification, and 2% were on oral hypoglycemic agent and insulin. This table shows 27% were having normal visual acuity, 23% were having visual acuity between 612 to 618, 21% have even less visual acuity, 624 to 636, 12.5% were having even less visual acuity. Majority of the patients were having venous engorgement, microaneurysm, followed by exudates, hemorrhages formation. Neovascularization was seen in very few patients. 95% were having random blood sugar more than 140 milligram per deciliter. 25% were having normal blood sugar value. This table shows severity of retinopathy with HbA1c level. Less than 6.5%, most of the people fall in mild to moderate NPDR group, and more than 6.5% falls into moderate to severe NPDR. This table shows retinopathy with total cholesterol. Less than 200 milligram per deciliter, most of the patients fall into mild NPDR group. 200 to 239 fall into moderate NPDR with 6% shows CSME, and more than 240 milligram per deciliter mostly fall in severe NPDR with 9.1% in CSME. This graph shows association of serum lipid levels with stages of diabetic retinopathy. So out of 120 patients, 70 patients were having HbA1c more than 6.5% and 30 patients were having less than 6.5%. Thus, there is a statistically significant correlation between the presence of diabetic retinopathy and HbA1c level. Increased cholesterol level were also seen with increasing severity of diabetic retinopathy. A statistical significant correlation was observed between the severity of diabetic retinopathy with HbA1c level and serum total cholesterol. However, there was no correlation between any other lipid parameters. Dyslipidemia and high blood sugars are identified to modify risk factor in diabetes mellitus. Vision impairment could be prevented, which is one of the direct complications with early diagnosis and treatment. These are my references. Thank you.
You studied incidence of proliferative diabetic retinopathy is more when the serum lipid is higher,
Yes, sir.
right? So, what about CSME? Because lipid impacts the CSME, lipid level.
Yes, sir.
Have you did the OCT, but you did not show the OCT thickness CMT correlation with the, that you should have done, correlation of CMT with your serum lipids. That will tell us whether it does impact the macular edema or not. Okay, thank you. Dr. Rohit Kumar Mahato. He is going to present the compare the efficacy between the first dose of intravitreal ranibizumab and triamcinolone in BRVO patients. Correct?
Good afternoon, everyone. My topic is to compare the efficacy between first dose of intravitreal ranibizumab and triamcinolone acetonide in BRVO patients. Introduction. BRVO is the second most common retinal vascular disease after diabetic retinopathy with an incidence of 0.44% to 1.6%. It has many known ophthalmic and systemic risk factors including ACE, hypertension, hyperlipidemia, ocular hypertension and glaucoma. The most common cause of visual impairment in BRVO occlusion is due to development of macular edema. The pathogenesis of macular edema is associated with the hypoxia-induced production of VEGF that promotes angiogenesis and increased vascular permeability. Due to the short half-life of anti-VEGF drugs and continuous release of VEGF in the eye, repeated injections are often needed to maintain the intraocular drug concentration. Triamcinolone acetonide inhibits the interaction between leukocytes and endothelial cells by reducing the expression of P-selectin and IKM1, thereby alleviating macular edema. Ranibizumab inhibits the interaction of VEGF-A with its receptors on endothelial cells, preventing endothelial proliferation, vascular permeability, and neovascularization. The main goal of treatment is to reduce photoreceptor damage by decreasing the duration of edema. Nowadays, anti-VEGF injections are mostly preferred as the first-line therapy for macular edema in BRVO. Aim of this study to compare the efficacy between first dose of intravitreal ranibizumab and triamcinolone injections in BRVO patients. Material and method. In this prospective study, one eye each of 70 patients were taken. Two groups were taken. Group A consists of those patients who were given intravitreal ranibizumab and Group B consists of those patients who were given intravitreal triamcinolone. The study was conducted in accordance with the tenets of Declaration of Helsinki. Patient with diabetes mellitus, history of vitrectomy prior to intravitreal ranibizumab injection, grade laser photocoagulation, intravitreal triamcinolone injections, cataract surgery and other surgical procedures were excluded from the study. Written informed consent were taken from all patients after explaining the procedure. All patients underwent a complete ophthalmic examination which include BCVA measurement, slit lamp examination, tonometry, dilated fundus examination, OCT. Injections were given under proparacaine anesthesia in operating room, maintaining all aseptic and antiseptic measures. Injection was given through the pars plana route, approximately 3.5 mm to 4 mm posterior to the limbus, in temporal quadrant, directly into the fetus cavity with a 30 gauge needle. It was given in slow steady manner to prevent sudden flux through the fetus cavity, and PNB was done for 4 hours after installation of moxifloxacin eye drop. Patient was instructed to open the PNB after 4 hours and use eye drop moxifloxacin 4 times a day for 3 days. After 1 month, again ocular examination were done in each patient. Macular OCT was done for measuring central macular thickness. Results: 70 eyes of 70 patients were included in the study. The mean age was 57.50% years. Female were more in number than males. In group A, out of 36 patients, 14 were male, 22 were female. In group B, out of 34 patients, 13 were male and 21 were female. All patients are examined after first dose of injections at 1 month, keeping baseline with respect to BCVA, CMT and IOP. This is the table and graph showing the mean BCVA results after 1 month of injections, in which group A BCVA increased in 20 cases, remain unchanged in 13 cases but decreased in 3 patients. In group B, mean pre-injection BCVA was unchanged in 7 patients, increased in 21 cases but decreased in 6 patients. These are the table and graph showing the mean central macular thickness after 1 month of injections, in which it is increased in 6 cases and decreased in 30 cases in group A, and decreases in all but 2 of the cases which remain unchanged in group B. This is the graph and table showing the mean intraocular pressures after 1 month of injection, in which the difference between pre and post injection values was not significant in the group A, whereas IOP increased in 3 patients of group B. These were some of the pictures which were collected during my study period. So to conclude, there is no statistically significant difference between baseline and after first dose in both group A and group B. However, patients of group B has significantly higher IOP values after 1 month with baseline. Discussion: macular edema occurs in 90% of BRVO cases. Triamcinolone injection is cost effective, but regular checkup of IOP is needed in these cases. The treatment of macular edema in BRVO should be patient specific with consideration to patient characteristics and possible adverse effects. The main limitation of our study was shorter follow-up and limited number of cases. An advantage of our trial was the early results of the drug comparisons commonly used in BRVO treatment in the same study, which could be interesting to the retinal physicians. These are my references. Thank you.
Thank you. Good concept, but one point, you have used the time domain OCT, which may not be valid to compare this study. You should have used the serous rather than status, right? One. And number 2, there is no distinction among the phakic and pseudophakic or aphakic patient, because your IOP has got impact in phakic patients. In phakic patient, IOP rise is more, so that point has not been included in the study, right? Thank you.
Thank you, sir.
Mulaga, she is going to present about retinopathy and chronic kidney disease and observational study.
Good morning, everyone. I'm Dr. Shavni. My topic is on retinopathy and chronic kidney disease and observational study. Financial disclosure and no conflict of interest. Both the retina and kidney are low resistance end organs that are supplied by very small vessels. These vessels are highly susceptible to fluctuations in the blood pressure and blood flow. The pathologic and hemodynamic abnormalities occurring in both retinopathy and nephropathy are thickening of basement membrane and increased leakage. These are the causes of chronic kidney disease, where its highest is due to diabetes, followed by hypertension. Retinal pathologies are the ones which are responsible for sight-threatening complication. With an aim of highlighting the importance of ocular screening in patients with chronic kidney disease undergoing hemodialysis, and because of the scarcity of data on ocular manifestations in hemodialysis patients, this study is conducted. My aims and objectives to study the association between retinopathy and chronic kidney disease and ocular screening in patients with chronic kidney disease on hemodialysis by analyzing the fundus changes in these patients. Materials and methods. It's a hospital-based observational study which lasted for a period of 5 months from January 23 to May 23. And my sample size is 70 patients, 140 eyes, and it was conducted in hemodialysis unit of nephrology department, KGH. The inclusion criteria is the patients with end-stage renal disease undergoing hemodialysis. Exclusion criteria is cases with reversible renal disease and not willing to participate. A complete ocular examination including visual acuity, IOP measurement, anti-segment evaluation and detailed fundus examination with indirect ophthalmoscope was done, and fundus photographs were taken. Out of the 70 patients, 140 eyes with diagnosis of CKD, 58% constituted males and 42% constituted females. This is the age-wise distribution where most of the patients, around 54.28%, were in the age group of 40 to 60 years, followed by 31.42% who were in the age group of greater than 60 years. This is a graphical representation of the same. And the visual acuities of these patients were also considered. And here the visions were in between less than 6 by 18 to 6 by 60 in 41% of patients, followed by patients 38% of patients belong to the category of 6 by 6 to 6 by 18. The most common cause of visual impairment in my study was maculopathy, and the maculopathy was hypertensive retinopathy constituted 38% of the etiology for maculopathy, followed by diabetic retinopathy, which constituted 34%. Then the comorbidities in the patients are like the patients were diabetic, hypertensive, ischemic heart disease and malignancies were found as comorbidities, and both diabetic and hypertensive were around 21 patients. Coming to the fundus changes, hypertensive retinopathy constituted around 40% of my study, followed by diabetic retinopathy which constituted around 20%, then mixed retinopathy constituted 18%, then around 16.4% where the patients had normal fundus. Then in the diabetic retinopathy, the patients, moderate NPDR patients were around 7 number, followed by PDR which were around 4 patients were there in this. Then in hypertensive retinopathy, which constituted the maximum of my study, most of the patients were having grade 2 hypertensive retinopathy, followed by grade 3 hypertensive retinopathy, like 10 patients were in this category. Then coming to the discussion, the chronic kidney disease results in progressive deterioration of renal function and is independent of age and gender. In the present study, the most common retinal abnormality noted was hypertensive retinopathy. Majority of the patients in my study was having grade 2 hypertensive retinopathy. A degrading kidney function with advanced CKD can lead to increased blood pressure, and sustained elevation in the BP can deteriorate the kidney function. Out of the diabetic patients, 14 patients had diabetic retinopathy and 13 patients had overlapping features. Therefore, most of the patients with diabetic nephropathy had retinal changes. Majority of the patients had moderate NPDR, of which some patients were newly diagnosed and are not aware of the vision threatening effects of their systemic condition. And in my study, I had around 40% who were having hypertensive retinopathy, and diabetic retinopathy were 20%. It was in coordinates with some of the studies which were like Brijesh Singh, which had hypertensive retinopathy and 30.47%, diabetic retinopathy 12.45%, Charmati study, which was Charmati et al. Study, which had hypertensive retinopathy around 45% and diabetic retinopathy 26.78%. My conclusion is that retinal changes in chronic kidney disease are attributed to the underlying etiologies of CKD, mainly hypertension, followed by diabetes. As severe hypertensive retinopathy changes are observed in the CKD patients on hemodialysis, this study highlights the importance of timely screening and regular follow-up. Patients must also be made aware of the ocular morbidity associated with CKD. A multidisciplinary approach should be advocated in the management of patients with CKD. These are my references. Thank you.
All these patients were mobile patients, or did you examine them in the?
I went to the hemodialysis unit in nephrology, sir. Some of them patients, we have another OP in the same KGH. There I called them for anterior segment evaluation.
Yeah, no, I could see that you did check the vision. So, how it is possible to check the vision of your bedridden patient?
Thank you.
Good morning, everyone. I'm Dr. Amir. I'm presenting here ophthalmic manifestation sickle cell anemia patient at Tertiary Care Center under the guidance of P. Vishwamitra doctor and Dr. G. Mohan Preeti. No financial disclosure, no conflict of interest. Sickle cell disease is the most common hemoglobinopathy affecting humans, approximately 7.74 millions. It comprises sickle cell trait, homozygous sickle, and sickle thalassemia, hemoglobin SC. India has second largest population of sickle cell disease, over 1 million. The sickle cell mutation is seen among many tribal groups in India with prevalence of heterozygotes varying from 1 to 40%. First reported by James Herrick in 1910, the amino acid valine is substituted for glutamic acid via point mutation at position 6 of the beta chain of chromosome 11. In hypoxic condition, these RBCs undergo sickling that results in abnormal rheology and hemolysis affecting the microcirculation with disastrous consequences in the systemic circulation as well as in the eye. Coming to systemic manifestations, acute chest syndrome, painful crisis, hepatic and splenic sequestration crisis, and as follows. Coming to ocular manifestation, they have the anterior segment manifestations, posterior segment manifestations. Anterior segment have conjunctival comma signs or corkscrew vessels or iris atrophic patches. Coming to posterior, they had non-proliferative retinopathy changes and proliferative retinopathy changes. In non-proliferative retinopathy changes, venous tortuosity, Salmon patches, iridescent spots, and black sunburst. Coming to proliferative retinopathy changes, peripheral artery occlusion, peripheral AV anastomosis, CFAN configuration, vitreous hemorrhage, and retinal detachment. Aim is to study the ophthalmic manifestation sickle cell anemia patient attending a tertiary care center. Materials method of our study. Our study is a cross-sectional descriptive study done for a period of 3 months at Department of Ophthalmology, Andhra Medical College, Visakhapatnam. Of patients referred from the General Medicine and Pediatric Department who are diagnosed with sickle cell disease in a patient of sample 31 patients. Patient above 5 years of age who are diagnosed with sickle cell disease and who are willing to give written consent from patient, parents, or guardian for participating in the study are included in this study, and patient having other blood dyscrasias are excluded. Coming to methodology, patients are referred from the Department of the General Medicine and Pediatric. These are diagnosed in case of sickle cell disease by hemoglobin gel electrophoresis. Consent was taken and demographic data was collected. All these study patients were examined for ophthalmic manifestation with slit lamp biomicroscopy and detailed fundus examination with indirect ophthalmoscope. Statistical analysis done with SPSS version 20. Here are the results. Out of 31 patients, 55% were female and 45% were male. Coming to the age distribution of our study, majority of the patients were in 16 to 25 years and followed by 6 to 15 years, then followed by 26 to 35 years, and minority was in 36 to 45 years. In our study, 16% were from urban area and 29 were from rural area and 55% from tribal area. Genotype making of our study, out of 31, 13 were homozygous sickle cell and 10 were sickle cell trait and 7 were hemoglobin SC and one patient was sickle beta thalassemia. Coming to ocular manifestation, as you know, anterior segment findings shown here is conjunctival corkscrew vessels and comma sign that is including 61%. In our study, posterior segment findings shown non-proliferative changes in 58% and proliferative in 26%, and no retinopathy changes are seen in 16%. These are the non-proliferative retinopathy changes. Venous tortuosity is the majority of the thing, includes 58%, then followed by black sunburst, Salmon patches, and iridescent spots as seen here. These were findings of our patients. Coming to proliferative changes, peripheral artery occlusion was seen in 5 patients and peripheral AV anastomosis was seen in 3 patients. And in our patient, there were no retinal detachment or vitreous hemorrhage or CFAN configuration was seen. As compared with between proliferative and non-proliferative retinopathies in different genotypes, homozygous sickle and sickle cell trait has the majority of the population have non-proliferative changes, whereas in patient with hemoglobin SC, the proliferative and non-proliferative changes were near comparable. Coming to the discussion, our study sample was 31 and had female predominance, and majority of the age group was less than 25, And the study shows anterior segment findings majority of this seen as 61% in posterior segment changes and proliferative changes were seen in 58 non-proliferative changes were seen in 58% and proliferative changes were seen in 25.8%. Were compared with the Swati Samant et al., Mukherjee Khan et al., Kaushika Rotary et al. 49 and 146 and 36 were the sample size as respective, and Kaushika et al. Were in concordance with our study having a female predominance, and all these studies have majority of the population less than 60. And majority of the studies shown the common changes of anterior segment as the conjunctival venous tortuosity, that is concordant with the Mukherjee Khan et al. Also, and in proliferative and non-proliferative as also seen. Similar finding is seen by conclusion. Sickle cell disease is commonly associated with number of ocular manifestation if untreated that can affect the quality of life and vision. To prevent such consequences, once diagnosed with sickle cell disease, these patients should refer to the eye specialist for the screening and regular follow-up. The patient should know about the status of his disease and probable visual prognosis. These are my references. Thank you.
Didn't you consider studying the vision of this patient?
Sir, visual acuity was not included in the studies.
Okay. And you said it is a cross-sectional study. The cases which were included were referred to you from the department.
Yes, sir.
And you did not go to the community to find the case, right?
Yes, sir.
Good afternoon, one and all. Heading on straight to the topic, short literature on diabetic retinopathy. Diabetic retinopathy is a major microvascular complication of diabetes mellitus. The pathogenesis of DME starts with retinal hypoxia, resulting in hyperpermeability of retinal capillaries. Anti-VEGF treatment has demonstrated significant benefits for patients with DME. The capillary hyperpermeability is mainly attributed to hypoxia-induced upregulation of anti-VEGF. Now, diabetic macular ischemia causes visual impairment that is best seen in FFA through FAZ and CNP areas. A significant cause of defective vision is macular ischemia. In the presence of continuous anti-VEGF therapy, there is concern whether macular ischemia may increase. In an era of FFA and OCT denoting areas of FAZ and CNP areas, the lacuna in other studies are, despite the previous studies, there still lies a paucity on whether multiple anti-VEGF injections cause macular ischemia, as evidenced by few studies. Now, my aim to analyze the FAZ qualitative and quantitative changes in patients treated with intravitreal anti-VEGF injection in non-proliferative diabetic retinopathy and to correlate with the visual acuity. The study design is retrospective, study period January 2020 to June 2020. In a tertiary eye care center, 43 eyes of 36 patients were involved. Inclusion and exclusion criteria as mentioned. The materials and methods, we had taken general history presenting complaints, slit lamp examination was done, and the number of intravitreal injections at 1 month, 3 months, and 6 months. And the octa was done, and we had studied the parameters of horizontal and vertical diameter of the superficial and deep capillary plexus, area and circularity, fractal dimensions. Then the retinal vessel density and central retinal thickness. Coming on to the results and discussion. The total 43 eyes of 32 patients, including 18 males and 14 females, the mean age was 54.07 plus or minus 7.56 years, were included in this study. Changes in the FAZ horizontal diameter and vertical diameter in SCP and DCP showed no statistical differences. Changes in the FAZ area and FAZ ratio also showed no statistical difference. Changes in circularity in SCP and DCP also showed no statistical difference. Association with changes in the central retinal thickness and BCVA showed statistical significant difference, decreasing trend in all measurements from 1 month to 6 months, and the BCVA showed a statistically significant increasing trend in all measurements from 1 to 6 months. So the statistically significant changes were seen in mean central retinal thickness and BCVA during the course of intravitreal anti-VEGF injections in these eyes. The changes in the retinal vessel density in SCP and DCP also showed a decreasing trend from the baseline to month 6, decreasing trend again in the DCPs, and all of these were also statistically significant. The changes in the fractal dimensions in the SCP and CCP showed a decreasing trend from the 1 month to 6 months, and again in the DCP also it was a decreasing trend, and this also was statistically significant. Coming on to discussion, our study showed that the horizontal diameter, vertical diameter of FAZ in both SCP and DCP statistically unchanged during the first 6 months. Fuchs et al. Noted enlargement of FAZ in 6 to 8 weeks after one intravitreal injection of bevacizumab. Gill et al. Noted FAZ area decreased over time in both observed and treated eyes with DME. Our study was consistent with the previous studies, showing FAZ area remains statistically unchanged. Coming on to the other studies, Chenna et al. Reported no significant association between severe macular ischemia and poor visual outcomes. Betts et al. Reported decreased macular edema as a result of anti-VEGF treatment. Dovali et al. Reported that the macular ischemia may have a negative impact on the functional outcomes, but there was no anatomical outcomes. Our hypothesis: the anatomical swelling in the eyes with DME is a factor in widening of the FAZ by pushing the capillary centrifugally. The effect of DME on FAZ and its interaction with anti-VEGF and macular thickness makes analysis more difficult in these eyes. Now, what we found in 2 patients, the FAZ increases in these patients, and that was mostly involved in the deep capillary plexus. The large diameter in the capillary plexus plus a normal superficial capillary plexus gave a good response to anti-VEGF injection. Larger FAZ was associated with poor prognosis and presence of drill. Now, as we did the injections for the first patient, regression of intraretinal cyst was observed in the first anti-VEGF injections, and after the subsequent OCTA found a false increase in the FAZ area, denoting falsely interpreted macular ischemia. That was also seen in the second patient that we had discussed. Circularity in superficial capillary plexus and deep capillary plexus, Kravitz et al. Showed significantly.
Conclude, please.
The retinal vascular density limitations of our study. The fractional diameters showed a reduction in the FDs. The Lee and Dexter also showed a decrease in the FDs. In our study, there was a significant reduction in the fractional diameters. Limitations, the study was a very short follow-up. It was only 6 months, so we could not assess the FAZ. Small sample size. We had not included anti-VEGF injections, level of control of diabetes, PRP levels, and the effect of OCT, other OCT biomarkers. Conclusion, ours is a pilot study that involves, shows a resulted in decreased CRT and improved BCVA, thus implying anti-VEGF injections had no deleterious effect on macular ischemia. The regression of intraretinal cyst following anti-VEGF injections can falsely interpret increased FAZ area, indicating a false macular ischemia. Greater samples and longer follow-up period can be needed to confirm our findings. Thank you.
So, these are all findings after just one injection or multiple injections?
Multiple injections up to 6 months.
But that factor and that
Yes.
duration all has been
Yes.
considered?
Yes.
Okay, thank you. The next presenter is Dr. Rakesh Kumar. And he is going to present to us the study of correlation between SB1 and diabetes and macular edema and tertiary eye disease.
Good morning, everyone. My topic is correlation of HbA1c level with diabetic macular edema in a tertiary care hospital. The term diabetes mellitus describes a metabolic disorder characterized by chronic hyperglycemia with disturbance of carbohydrate, fat, and protein metabolism. The disease has acquired the status of global pandemic. The number of people with diabetes in India currently around 101 million, and India is now the diabetes capital of the world. Diabetic retinopathy and diabetic macular edema are common microvascular complications in patients with diabetes and may have eventually leading to blindness. The level of glycemic control in patients with diabetes has been linked with occurrence of macular edema. The WESDS showed that 1% decrease in the HbA1c from the baseline to the 4-year follow-up would be expected to lead to 25% decrease in the 10-year incidence of macular edema. The aims and objectives are to study the correlation of HbA1c level with diabetic macular edema, qualitative and quantitative assessment of macular edema using OCT, and to correlate the foveal thickness with the HbA1c level. The inclusion criteria: diabetic patient as diagnosed by the ADA guidelines 2022 having various grades of retinopathy were included. Both sexes were included, age between 10 to 70 years. The material answer method: this is a cross-sectional study was conducted in the Regional Institute of Ophthalmology, Guwahati Medical College and Hospital during the period of February 2022 to March 2023 in collaboration with Department of Biochemistry and Endocrinology. The patients were selected from the outdoor as well as indoor of the Regional Institute of Ophthalmology, Guwahati. The total of 140 patients were taken and divided into two groups based on presence of and absence of macular edema, 70 patients each. A complete history was taken, general examination and systemic examination, and signs of any complication of diabetes were noted. Ocular examination was done very meticulously in every patient with the following emphasis: visual acuity, intraocular pressure, detailed cilium examination. The pupil was dilated with topicamide 0.8% and phenylephrine 5% eye drops, 1 drop thrice at 15 minutes interval, and detailed posterior segment examination was done with direct and indirect ophthalmoscopy, cilium biomicroscopy with 90D lens. Fundus photographs were taken with the fundus camera and grading of retinopathy was done. OCT imaging was performed using the Stratus OCT machine model 3000 Carl Zeiss machine with software version 4.0. Laboratory investigation was done: routine examination of blood, hemoglobin, TC, DC and ESR, routine examination of urine for sugar, albumin, partial cast and RBCs, serum separation of FBS, PPBS, serum creatine, and glycosylated hemoglobin estimation was carried out by modified chromatic method. Coming to results, in group 1, the age of patients entry were 24 to 70 years, and the largest number of patients, that is 32 patients, were age of 50 to 59, followed by 17 patients age of more than 60, and lowest two number of patients with the age between 20 to 29. In group 2, the age of patients ranges from 18 to 70 years. The age group 40 to 49 years are maximum number of patients, that is 26. In the out of 70 patients in group 1, 14 were female and 56 were males. In group 2, 19 were female and 51 was male. So more number of male patients was found in our study in both groups. In group 1, the longest history of diabetes was 25 years and the least was 6 months. So the mean duration is 11.51 years. In group 2, the mean duration is 9.39 years. The longest history was 22 years and the least was newly diagnosed diabetes patient. In these results, we can see the insulin and oral hypoglycemic agent in group 1 is 34 patients out of 70 patients, and in group 2, insulin was taken by 21 patients out of 70 patients. So p-value come out 0.0378, which is significant. And the lifestyle of the patient: moderately active is 99 patients, sedentary was 22 patients, and active patients were 19 out of total 140 patients. In grade of retinopathy, mild NPDR is seen in group 1 2 patients and group 2 in 18 patients, moderate NPDR in 41 in group 1, 47 in group 2, severe NPDR in 14 in group 1, 3 in group 2, PDR in 13 in group 1 and 2 patients in group 2 patients. In OCT patterns in CS, those patients having CSME, the total number of eyes is 70 and the cystoid was 70, serous detachment was 8% and ventricular traction was 4 patients. Now coming to HbA1c level and HbA1c level and diabetic macular edema, the mean HbA1c level is 9.343 in group 1 and 8.42 in group 2, and standard deviation was plus minus 2.2 in group 1 and plus minus 1.5 in group 2. And the maximum HbA1c level was 15.3 and foveal thickness was 542 millimeter and minimum was 5.9 and minimum foveal thickness was 266 micrometer. Now coming to discussion, in our study the mean HbA1c group 1 is 9.343 and group 2 is 8.427 and the p-value is coming out to 0.0047, which is considered significant, and this is also shown in the study of WHDR. We also correlate the foveal thickness with HbA1c level, and the correlation coefficient is 0.2258 and p-value is 0.0602, which is not that significant in our study. In the present study, the group 1 14 were females and 56 were males, so it is found in more in males patient, which is also seen in the another study. And in our study, mild NPDR present in 2.86% in group 1, 25% patient in group 2, moderate NPDR in both groups was 58% and 67% respectively. CVD NPDR is 20% and 4% in both groups, and PDRS 18.57 and 2.86 in both groups respectively, which is also seen a study in the Young et al. So in conclude, we can say hyperglycemia is the most important modified risk factor with diabetes. There has been a more widespread availability and standardization of HbA1c level in recent years. High mean glycosylate hemoglobin levels were significantly associated with development of macular edema in patients with diabetic retinopathy. Also, glycosylated hemoglobin levels have been positive correlation with foveal thickness on OCT, though not found
Conclude, please.
statistically significant in our study. Even new risk factors and mechanisms of disease have come into light, but HbA1c level and glycemic control is more valuable in diabetes patients. There is no conflict of interest, no financial support. These are my references. Thank you.
Thank you. I think all papers are over. Now we are looking for keynote address by Dr. Aishwarya Mohanty, who is the AIOS Diabetic Retinopathy and Medical Retina Award winner in first midterm conference, Patna. So the topic is OCT, can it be a predictor of eclampsia? Please.
Yes, sir. Good afternoon, everyone. Myself, Dr. Aishwarya Mohanty, is going to present on OCT. Can it be a predictor of preeclampsia? There is no financial interest. Preeclampsia, being the leading cause of maternal mortality, especially in developing countries, has a prevalence of 3 to 8% of pregnancies. As we know, it is a multi-system disorder. Coming to pathophysiology of preeclampsia, reduced blood flow to placenta due to fibrosis of the spiral arterioles. It leads to placental hypoxia and ischemia. Firstly, it leads to fetal growth restriction leading to IUGR. Secondly, there is release of pro-inflammatory proteins into maternal circulation, which in fact leads to endothelial dysfunction leading to systemic vasoconstriction, which in fact leads to maternal hypertension, and there is major organ damage like in kidney, retina, liver and brain. Symptoms are most common in third trimester, including blurring of vision, photopsia, scotoma, diplopia. Ocular findings include conjunctival vascular anomalies, hypertensive retinopathy, choroidopathy, exudative RD, vitreous hemorrhages. Earlier, there were very few clinical studies regarding the retinal changes in eclampsia and preeclampsia, as objective and quantitative retinal imaging methods were lacking. So my aim is to study the RNFL changes in the pregnant woman with gestational hypertension and establish the potential contribution of OCT as an eclampsia predictor. It was an observational prospective study including all the patients in the age group of 18 to 45 years diagnosed with gestational hypertension by the Department of Obstetrics. We excluded pre-existing diabetes, hypertension, renal disease and any other retinopathy. An informed consent was taken from 35 patients after satisfying inclusion-exclusion criteria. Details pertaining to medical history, family history of hypertension, age, parity, gravida, BP, baseline data all were recorded. A comprehensive ophthalmological examination including external examination, BCVA, slit lamp, IOP, fundus evaluation and peripapillary RNFL thickness was measured at first visit at 28 weeks and 2 months postpartum by HD-OCT. The severity of PIH was classified into mild and severe preeclampsia and eclampsia according to ACOG guidelines. Now highlighting the results and discussion, maximum of the study population belonged to the age group of 20 to 40 years. One of my youngest patient was of 20 years. There were 23 primigravida and 12 multigravida patients and maximum of them belonged beyond 30 years of age group. According to ACOG guidelines, there were 28 mild preeclampsia and 7 severe preeclampsia patients. On comparing the RNFL thickness from first visit to 28 weeks of gestation, in the mild preeclampsia group, 7 had thicker RNFL, 15 had no change, 6 of them had thinner RNFL. And in the severe preeclampsia group, 4 had thicker RNFL, out of which 2 patients ended in eclampsia with new onset convulsions who were terminated emergently, and 3 of them had no change. The mean RNFL thickness in the severe preeclampsia group at first visit was 96 micron and at 28 weeks was 101 micron. At the same time, there was no significant change in mild preeclampsia group. Highlighting the retinal changes, 13 patients had no hypertensive changes, 7 had grade 1, 6 had grade 2, 5 had grade 3, 3 of them had grade 4 hypertensive changes and 1 of my patient had exudative RD. Reddy reported that there were 53.4% retinal changes in the preeclampsia group and 71.2% eclampsia patients. These vascular changes in the retina, they typically correlate with the severity of systemic hypertension. Therefore, observing the retinal changes can help in assessing the disease severity. With that, I would like to conclude that preeclampsia was more prevalent among the elderly primigravida. There was thicker RNFL layer thickness in the severe preeclampsia group from first visit to 28 weeks of gestation. And likewise, there was no change in the RNFL layer thickness in the mild preeclampsia group. So on OCT with ocular fundus changes, it can predict the maternal risk, diagnose the patient early, and guide the obstetrician in early and proper management. So fundoscopy should be made compulsory in all pregnancy-induced hypertension patients, especially in elderly primigravida during the antenatal visits, and there should be frequent follow-up. HD-OCT can be used as a routine screening tool in all those patients to detect the retinal changes before any vision-threatening complications can occur. Thank you.
Yeah, very innovative.
Thank you.
But only one question I have.
Yes, sir.
Do you think OCTA has got some role to play?
So we can only predict the mine. I had only 35 patients, so a large multicentric. We can at the same time we can check the macular thickness, choroidal thickness, and RNF. Yes, sir. Everything it can be done in a large population. Then only we can generalize it to the whole data. Thank you, sir.